Good evening, sir.
Very good evening.
This is a very auspicious day, sir. India has won the first gold medal in Olympics today.
Congratulations to all.
Yeah, let us congratulate every one of us. And
Yes.
This is also auspicious because today we are conducting with the 63rd issue of our
Webinar.
webinar series, and this is in continuation for last 1.5 years. And with new faculty, we have new learnings every week. And today's topic will be breast cancer screening and diagnosis by Dr. Mohit Agarwal, who is Additional Director of Medical Oncology from Fortis Hospital, Shalimar Bagh, and Dr. Rajiv Kumar Jain, our Senior Vice President of AUSD. So before we start the webinar, sir, let us have a welcome address from you, sir.
Thank you, Dr. Sandeep. Good evening, friends. I welcome you all to this 63rd issue of our webinar. And today's topic is important in this aspect that over the last 1.5 years, many patients they were reluctant to come to the hospital, especially for the screening purposes or for smaller elements. And some of the established cases of cancer, they really suffered a lot because they were not visiting hospitals. So today we have got Dr. Mohit Agarwal, who is a leading oncologist. I welcome you, Dr. Agarwal. I welcome our second speaker, Dr. Rajiv Jain. And with these words, I welcome all the participants to this webinar. Thank you.
Thank you, President, sir. So I again welcome you all for this webinar. This is a 63rd issue, and in this COVID time, actually we have been meeting almost every week and deliberating on the issues which are there, and we keep ourselves updated with the latest on the COVID and how to manage the non-COVID problems also with senior faculty members from across India. Dr. Mohit, for your information, this is an association of industrial doctors from various government organizations, Indian Railways, public sector undertakings, and then private corporates across India. We have got about 3,000 members, and in India, in Delhi, we have about 250 members, 250 plus, and these are all either medical heads of different organizations or they are in some senior positions. So, and this particular webinar we have been conducting for our members every week, and this is live telecasted on the YouTube also, and all the previous editions, they are available on our DigiConnect YouTube channel, and that you can access also from there, all previous editions, and this edition will also be uploaded as soon as the session is over. And today the topic is very important for us as industrial physicians, because breast cancer is really a menace across India, and diagnosis is very important because tiny lumps, they have been either people are missing, they are not aware of self breast examination, or during their annual medical checkup in our organizations, they are not properly examined. What are the guidelines for screening, and what is the correct method for diagnosis as early as possible, so that since FNAC came, a lot of early diagnosis, they are being now there, because FNAC gives a fair idea of what this cellular morphology of that particular tumor is, whether it is a benign or a malignant. Accordingly, a lot of early diagnosis leads to early treatment intervention, either in the form of partial mastectomy or radical mastectomy, or now modified radical mastectomy, or now a lot of treatments are also there in the field of medical oncology in the form of targeted therapies, immunotherapies, and other things. So we would like to take your advice on how this breast cancer screening and early diagnosis is possible, especially in our female employees, in our family members, in the masses where we are doing all these examinations. So, and for the participants, may I introduce Dr. Mohit Agarwal. Dr. Mohit Agarwal is Additional Director of Medical Oncology from Fortis Hospital, Shalimar Bagh. And he is a dynamic medical oncologist with nearly a decade of clinical experience. After completing his MBBS from Maulana Azad Medical College and MD from Lady Hardinge Medical College, his firm belief that cancer care is possible led him to pursue medical oncology from Rajiv Gandhi Cancer Institute. Finding awareness and myths as the biggest barrier for cancer treatment, he has started his Stop Cancer initiative, which involves lectures, CMEs at national, international forums, and patient assistance program. He has wide experience of treating solid and hematological malignancies, and his key area of interest are breast, lung, gastrointestinal, genitourinary, hepatobiliary, and lymphoma. His expertise includes all the type of chemotherapy, included targeted therapies, and he has been accredited with European certification by European Society for Medical Oncologists, and he is actively involved in clinical research in cancer. He is a teacher faculty involved in teaching of medical students pursuing the medical oncology and a thesis guide for them. And he has been a speaker, panelist, and chairperson at various national forums. And he has also got multiple research papers in national and international journals. So this is a small introduction about Dr. Mohit, and our second speaker is Dr. Rajiv Kumar Jain. Dr. Rajiv Kumar Jain. Dr. Mohit, may I tell you that our president and our vice president, Dr. Rajiv Kumar Jain, all of them, they are from Maulana Azad Medical College only. And even our treasurer, Dr. S.P. Chaudhary, Dr. Shashi Bhushan, they are all, many of them, they are from Maulana Azad Medical College. They might be your seniors. And Dr. Rajiv Kumar Jain, he is Senior Consultant Health in Indian Railways with 40 years of experience in health and hospital administration. He is basically a pediatrician and a public health physician and an occupational health physician. And he has published, presented more than 145 scientific papers in national and international books and journals. And fellowship is scholarship by WHO, National Institute of Health, Canadian Society for International Health, and International Clinical Epidemiology, and International Society for Priorities in Healthcare. So we have got two learned speakers today for the information to all the participants. And Dr. Mohit, now you can start your deliberations on about the breast cancer screening and early diagnosis so that we all can be benefited. And this is a great opportunity today. And as I told you, this is an auspicious day. And on this auspicious day, you are also connected with us on this platform. We'll have a great further connections also. Maybe when the this COVID norms are relaxed, we'll have some physical meeting, and we'll have a physical meeting in new working norms. So Dr. Mohit, floor is yours.
Thank you, Dr. Sandeep. Thank you for such a generous introduction. And thank you, Dr. Gajendra, for inviting me over here. First of all, congratulations to all. We have just won the gold medal for the first time in the track and field competition. So already the spirits are very high. Now, regarding, you have already told in my introduction that I find the barrier to cancer care, the biggest barrier is the awareness and the myths and the facts. So I have broadened my presentation today, and what I have done today is that I have been speaking about my clinical experience with the patients, obviously focusing on the breast cancer screening and early diagnosis, but the queries which patient comes to me when they come to me in the OPD, and I'm sure that you all are practitioners working at very good institutes and places. So when the patient, and maybe the patient at the initial time of diagnosis the diagnosis is made by you people. I am only the referral doctor. Once the diagnosis has been made, the patient is referred to me. So I'm pretty sure that these questions must be asked to you. So maybe this would enlighten all of us and have a better approach to the patient. So with your permission, I would like to start my presentation.
Yeah, sure.
So can I share my slides?
Yeah.
Yeah, sure. Just a second. So I hope my presentation is visible to everyone. Is it so?
Yeah. Yes, sir.
Yeah. Okay. So let's talk about the big C and okay, so we are not going into details of cancer because we are talking to doctors only and we all know, but this is a very good definition of a cancer, not in exact pathological terms. And Mr. Alan Jackson said that it is a scary word. So whenever somebody asks me that what is cancer, I said it's a scary word, but what does it actually mean? We'll be coming and discussing about. So we'll not be talking about this. So as I told you, that my presentation would be most focused on the questions which patients comes to me when they come to me my OPD. So this is a very common myth or fact, whatever you say. So when the patient comes to me and I disclose that maybe that patient is suffering from a malignancy, they say that, you know, I have never been ill, never ever taken a tablet of crocin in my life. It is unlike, is it possible that I would have had a cancer? So the answer, obviously, we all understand, is cancer can affect any individual, age, gender, or race. And it is not necessarily that if you have been absolutely healthy in your prior times, one cannot develop malignancy. However, obviously, the more fit you are, the chances of any disease decreases. Secondly, a very important question, and this is very common amongst breast cancer patients, because once we diagnose a breast cancer in a lady, they are very disturbed about the fact that whether their daughters would be having so, or even a daughter ladies comes to us and say, my mother has just been diagnosed with cancer now. That what does that mean? What does it imply for us? So a positive family history is very essential in the diagnosis of cancer, whether it's a myth or a fact. So the answer is a complete myth. I always tell my patients that a positive family history is only seen in about 5 to 10% of the patients suffering from cancer, and rest of the 90% patients are sporadic. So a lady who has developed a breast cancer, there are 90% chances that the siblings, the daughters won't develop so. So the question again, as I was referring to previously, a patient mother was diagnosed with breast cancer at the age of 65 years. Is it sure that she will also get cancer? This is what I was talking about. So as I have always, as I have told in my previous slide, obviously not sure at all, because majority of breast cancers are sporadic. So how much breast and ovarian, I have included the ovarian part also because they come into a syndromic part. So how much of the breast and the ovarian cancer is hereditary? And if we see this diagram, we can very well see that there is a familial clustering in about 15 to 20% of the patients, but fine genetic predisposition or a hereditary pattern is found only in 5 to 10% of the cases. So this is important, so that we can relieve the patient's anxiety on the fact that whether if somebody has developed a malignancy in their family, especially a breast cancer or an ovarian cancer, it does not absolutely mean that their other members would be developing so. So how do you order a genetic test for a relative of a patient suffering from cancer? So this is a very common question asked to us, that, you know, once a diagnosis of cancer has been made, now when do you order a genetic test? That means whether you do it for all patients who have been developed from who have been diagnosed as a breast cancer. So these are the few points which we take into consideration, especially in the case of a breast cancer, that if any of these criteria are being met, then we order a genetic testing. And what are those? Those are if 2 or more generation of patients are suffering from cancer. So supposedly the mother, the grandmother, or the mother's aunt, or anyone is suffering from breast or an ovarian cancer. Then you have a very young patient. like less than 30 years of age, who have a breast, ovarian, or colon cancer. Male breast cancer, and we all know, being doctors over here, that breast cancer can also happen in male, but male breast cancer has a high risk for genetic predisposition. So if a male breast cancer is found in the family, then one should order a genetic test. And simultaneous occurrence of a breast and an ovarian or colon cancer in an individual. So supposedly a lady has come to us who has been diagnosed as a breast cancer, and she prior has a history of an ovarian cancer as well. That means that there is simultaneous occurrence of two cancers, malignancies in the same individual. Then that means that there might be some genetic risk for that, and you should order a genetic testing. Now, what genetic testing should be ordered? Though it is freely available now in every lab, but you need a genetic counselor, because it has a lot of medical legal implications once you diagnose a patient with a genetic cancer, because then that would run in the family, it would have insurance implication. So you should not order a genetic test straight away. A proper counseling needs to be done, a consent needs to be taken before ordering any genetic test, something for a running in the family. So what are the most important risks for cancer? And this is generally, I'm not talking about breast cancer. What are the most important risk factors for cancer? And we know that there are many risk factors for cancer. But if you see worldwide, across all ages, across all races, ethnicities, genders, this is the most common cause of cancer, which is modifiable. And this is one factor. If eliminated, the every chances of most of the malignancies would decrease. So just to bring about that, how I really wanted to bring about the fact, because today we were talking about occupational and health exposure and everything. So I wanted to bring about the fact that how does this smoke affect us? So just a pathological picture. These are two pictures. This is a normal lung on the left side. This is a smoker's lung, where you see all that tar is deposited, and you see here that this tar subsequently leads to this white florid proliferations turning into a malignancy. So this is a normal lung transforming into a smoker's lung, subsequently into a lung cancer with exposure to smoking. So the question is that, when patient comes to me and they start talking to me, and they tell me that, see sir, hum to zindagi ji chuke. We are happy smoking. We are not afraid of dying. Why the hell you are bothered? So the answer is that the risk is big. Half of the individuals would be killed. Amongst those, 1/6 would die of lung cancer, and even the chances of breast cancer increases in a smoker. Most 25% of those individuals die in the middle age, 35 to 69, when they're actually most productive to the country, economy, and to their family. And the stopping of smoking works. That is, it reverses the change, and your chances of developing a malignancy reduces. So this was one of the photograph of my patient. Just to show the level of addiction the patient had. This patient had some head and neck malignancy, and we had to tracheostomize the patient. So once I was moving out of my hospital, I saw this patient poking his cigarette into the tracheostomy hole. So I just took a snap of it and removing his hand. With this permission, I always show it in most of my presentation, that this is the level of addiction that the patient has. So yeah, this was the point I was bringing about, that patients say that it's my life. Let me smoke. Why the hell are you bothered? You say that it is going to be reversed. You'll add years to your life. I don't want to live more. What is your concern? So the answer to this is also there, that once you are living with your family and you're smoking over there, a non-smoker's risk of lung cancer increases 30% when living with someone who smokes at the home. So somebody who is smoking at home, and the person who's not smoking, who's not addicted, there is a 30% increased chance of lung cancer. And way back in 2001, we had a data that second-hand smoke kills 60,000 non-smokers nationally each year. And believe me, that was the year 2001. Now we are talking 2021. This figure must have added 1 or 2 zeros more. So smoking kills, and the risk factors for other cancers we can generalize into tobacco, alcohol, viral infections, sedentary lifestyle, obesity, high caloric Western diet, and these all are common to most of the malignancies, including breast cancer as well. So second question most patients will ask is that, my uncle was treated at a hospital. He didn't require surgery. He still got cured. Why are you insisting for surgery? So the question here is that, is the treatment for all malignancies same? And as all doctors, we understand, but the patients do not understand that cancer is not one disease. It is a group of different diseases with different modalities of treatment, with different prognosis and different cure rate depending upon the site of origin. And then what are the warning signals of cancer are very important. These are general warning signals of cancer, because even when anyone comes to know that I am a cancer specialist and I am into some form of a meeting or a party or somewhere, people say, sir, हमको कैसे पता लगेगा कि हमें cancer है? Should we get some tests done? So I always tell them that these are the 7 warning signals of cancer which should be taken care of. That is, whether there is a change in the bowel or bladder habits, there is some sore or ulcer that does not heal, there is unusual bleeding or discharge from any side, be it the rectum or be it from the oral cavity, there is a thickening or a lump in the breast or elsewhere, there is some difficulty in swallowing or indigestion, there is a change in the wart or a mole which have been there for long, and nagging cough or hoarseness which persist. We need to understand that most of these patients turn out to be tuberculosis in our country, but mind you, most of them patients are being treated as tuberculosis though they have a malignancy, because the biopsy is not done. So if even on initiation of ETT, when you suspect that the patient has tuberculosis and these symptoms persist, one should insist on getting a further biopsy or something to rule out a malignancy. So how is cancer diagnosed? And this applies to breast cancer only. Biopsy. So biopsy is a must. Now these days, FNA has taken a back seat when we talk about breast cancer, because we need to have a tissue to understand the biology of the tumor. But then there's a big myth that people say that they have heard that the moment you cut through the cancer, that you go for a biopsy, the cancer would spread. So let me tell you that there has been a lot of research and studies which has shown that once you do a biopsy or an FNA, the cancer does not spread. Even you cannot make a diagnosis of most of the malignancies unless and until you get a biopsy or an FNA. So cancer does not spread as a result of biopsy. So this is a form of biopsy we do. Second, usually we know that patients always, these days we have health packages, and most of the labs are getting these blood tests done, the hemogram, the kidney function test and liver function test, and patients do it on a periodic basis just to see whether they're normal or not. So these reports are normal, but then these reports being normal does not necessarily mean that one cannot have a cancer. So the 7 warning signs which have illustrated before should be taken care of, and if those signs are there, one needs to consult a specialist rather than just being concentrated on the blood reports and the these hemogram profiles. The question again comes is that the moment some patients are in a hurry, they say that the moment you are diagnosed, the treatment should start early or the disease would spread immediately and the problem would be there. So what we need to understand here is that we need to stage our patients first and then only decide about the treatment, because stage would tell us that what treatment to give and what outcome to expect. So what are the stages of cancer? And this would be general, even for breast cancer. We have a stage 0 where the cells are, the malignancy is only inside the cell. It is the early form. Stage 1 is localized, when the disease slightly increases from localized to a slightly advanced form. It is locally advanced, stage 2. And when it is on the verge of metastasizing, then it is late locally advanced, stage 3. Once it has gone to other parts of the body, it is stage 4. What the problem we face in India is that though in Western countries, especially for breast cancer, patients are diagnosed at stage 1, 2, or 3, here in India, about 80% of the patients are diagnosed at stage 4, which really decreases the chance of complete cure. So this we need to emphasize regarding the breast cancer screening and the awareness, that once they have a lump or any problem, the patient should consult a specialist. I get in my OPD patients who come to us and shows a lump in the breast. And then when I ask them that how long it has been there that they have noticed this lump, they tell it is 2 or 3 years. When I asked them that why didn't they actually consult a specialist, the answer is that they were too shy to show it to a doctor. So go to a lady doctor if you are shy, go to any doctor you can have faith on, go for some test if it is required, but please do not hide away with any. So is surgery advisable in all the cases? So as I have told you, not really. It would be depending on the stage of the disease. Is more always better? So we need to decide the modality of the treatment depending upon the stage of the disease. And is surgery always the first option? Not necessarily. When you have a stage 3 disease, you need to downstage the disease by giving chemotherapy and then go ahead with the surgery. So another question which comes very commonly to the patient's mind is that once the option of surgery is given to them, whether a breast conservation surgery or a modified radical mastectomy, because breast conservation surgery would just remove the lump, while modified radical mastectomy would remove the entire breast. So which should be done? So people believe that removing more would be better, but there has been a big trial, NSABP06, which has shown that oncologically, both of these modalities are equal in terms of outcome. So if your doctor is comfortable and feels that breast conservation surgery can be done, that would be the best modality to get rid of the disease. And it is not really necessary that one has to go for an MRM. Now comes the part of the radiation, and patients feels that this is their general perception that you want to burn me. So radiation, we all understand that it is an ionizing radiation, and there is nothing like burn. Obviously, there might be skin changes, but it is necessary in some aspects of the disease, and if required, so it should be given. Now comes the question of chemotherapy, and when I talk about chemotherapy, the patient thinks that I'm talking about something like a poison, something like a rat poison. So let us understand some facts of chemotherapy. People feel chemo is very painful, but on the contrary, chemo is absolutely painless. It is just like giving an IV fluid. So once you give chemotherapy to the patient does not even come to know that the chemotherapy is being given. There are long-term side effects of the chemotherapy? Surely there are, but if you are given by an expert with a proper care and term, the drugs are given in such a doses that the long-term side effects are negligible. Patients feel that they should be placed under house arrest, and once chemotherapy is given, they'll be bedridden. On the contrary, when I treat my patients for any sort of malignancy, be it a breast cancer, I ask them to join their office the next day, because it is not absolutely required to go under house arrest. The only thing which is required is that if you are feeling tired, you should take a break, but they can resume all activities what they were doing previously. So the question which Dr. Sharma also told about the new targeted therapies. So what are the targeted therapies? When we talk about chemotherapies, they are the drugs which act on replicating cells, while targeted drugs identify a target on the cell surface which is going to kill those cells. So are they available for all types of cancer? No, they are only available for a few types of cancer on which we have a targetable drug. So they are very well available for breast cancer. Then the question is, these days we are going into an era of personalized medicine. So supposedly I have two ladies with same age, height, weight, with same stage of breast cancer. The treatment might be absolutely different and the outcomes might be absolutely different depending upon the biology of the disease. So it is not the stage only. These days we talk about the nature and biology of the disease as well, and I might not elaborate more on this because we all are doctors over here whom we are talking to. This is much more told to the patients. I always tell my patients that supposedly you have two kids in the same class being taught by the same teacher. One scores 90, other scores 40. So it is the biology and the nature that we are more concerned with these days. So this part, whether surgery, chemo, radiation, 100% that will be cured, we know that is not there. 100% cure is not possible. Now, the last topic which I really wanted to cover was the cancer screening. So what are the drugs which what are the cancers where you can go for a cancer screening, and especially the breast cancer? So we need to understand that, the size of the lump initially might be very small to appreciate by hand, and mammography is nothing but just an x-ray of the breast. So what happens is that screening means examining an individual through some test when the patient is not symptomatic. So we are not talking about patient who has symptoms or some sign. We are talking about patients who are asymptomatic. So what are the guidelines for mammography? Different countries and different groups have different guidelines, but in general, any patient more than 40 years, any lady more than 40 years of age should annually have a breast mammogram to diagnose a breast cancer as early as possible. And if 40 is not there, 45 is their absolute cutoff. After 45, it is must. And I think if I was going through a data, the penetration of mammography is only to a tune of 1 to 2% in our country, screening mammogram. So there is where we are lacking and where to such an extent. So I'm not going to do screening guidelines of cervical cancer and lung cancer. Last thing I wanted to talk about, that people always talk about that whether there is some vaccine available for breast for cancer, and it is only for cervical cancer. As we all understand, which is Gardasil and Cervarix. It has a 98% protection rate to be given to individuals, ladies, girls, from age of 9 to 42 years. So do not believe that it is only till 18, 20. Any girl from 9 years of age to the lady till 42 years of age, preferably before marriage, should be given this vaccination, which has a protection rate of 98%. And this cervical cancer has a very high prevalence in rural areas, including areas of Haryana and UP. So we'll not talk about Angelina Jolie. The final part is whether this is a curable disease. I'm sure cancer is a curable disease, but we need to pick it up at an early stage. So I started with my word that whether what is the definition of a cancer? It is a scary word, but believe me, cancer is just a word. It is not a sentence. So with this, I would like to wrap up my presentation, and I would be happy to answer any question if there are.
Yeah, thank you, Dr. Mohit, for giving a very crisp and broad overview of the cancer management. And as you rightly said, that cancer is a scary word, but it is scary. Yes, it is scary, but the thing is, if it is diagnosed early, then it is curable. It is just like a common disease. Only thing is you need some sort of follow-up religiously that you have to do. And my question is regarding the screening for the siblings, the genetic test, as you rightly said that before going for genetic test, we need to see all the parameters, whether they really require genetic test or not. Their consent is also required and their counseling is also required. But still, if we have to go for genetic testing, then what are the genetic tests that you would like to advise to them?
So we really need to actually see that what spectrum of disease we are looking forward to. Supposedly, we are talking about the most common scenario, which is the scenario of breast and ovarian cancer. Then the most common genes implicated are of BRCA1 and BRCA2. So we order these BRCA testing in these patients where the indications I've already mentioned, which is more than 2 generations or a young breast ovarian patients, simultaneous involvement, or a male breast cancer patients. There are other syndromes also like Lynch, Lee-Fromeny, and other syndromes, but then they have to be clubbed and seen that what sort of diseases are being grouped together. Otherwise, nowadays, the labs are also offering a complete hereditary genetic panel where they test for each and every gene, what is there. But what we need to see from the patient is we need to make a pedigree chart. We need to see that what all malignancies are we implicating. The most common are the BRCA1 and BRCA2. And then after a proper genetic counseling, we can order the test.
Okay. So how, like these tests are only for once, and once they are at risk, then they have to be followed up later on.
So first of all, these tests are also not so straightforward. There are also 2 formats. One is the hereditary panel and the somatic panel, where you test by whether in the tumor or in the blood. But if we talk purely of the genetic panel, where we test in the blood, and if it turns out to be positive, then depending upon whether it is BRCA1 or BRCA2, you have different cutoffs where you need to start your screening protocols. That screening protocol would include screening for breast, also for ovarian, also for pancreatic cancer in males, and many other malignancies. So you need to make up a complete protocol and tell their family members as well to get themselves screened, whether they are also suffering from the same genetic lineage or not, and then to come up with a regular follow-up with those tests and on, so that we can actually pick up the disease early if it is so.
Okay. Then, Dr. Mohit, as you rightly said, that in India there is a lot of ignorance, and because of ignorance, we are getting our cancer cases detected at a later stage when they are either in stage 3 or stage 4, and when the treatment also becomes very difficult and very costly also, and it is really a bad days for the cancer patient and for the family also. And as you said that there are we have to watch for the warning signals. So these warning signals, day in day out, people are facing these sort of warning signals. But what should be the duration of these signals? Like yeah, if we have some off and on bleeding, maybe it can be due to hemorrhoids also. It can be due to some other factors also. If or some like sore is there, if it is not healing, so how, what should be the duration of watching these symptoms, warning
So,
signs?
so, sir, there's no as it is a cutoff. But what I usually tell my patients is that if any symptom is, in spite of taking expert advice from a doctor on an individual, is persisting for more than 4 weeks, then it is time to evaluate again and see that whether are we missing something.
So we should initially go for general management of that particular problem, and if it is not relieved, then you don't have to wait for more than 4 weeks. After 4 weeks, you should go for a specialist treatment, specialist advice whether there is any malignancy element in that.
Exactly.
Another
So,
questions, yeah.
yeah, where I see a problem is that patients assume diagnosis. So what happens is that the patient would have a bleeding PR, and they would assume and talk to a doctor on phone and something, you must be having hemorrhoids, and they would start taking treatment. Had they got themselves examined and that there are hemorrhoids, it's okay, then we know the diagnosis is there. But without a diagnosis, just assuming the assumption that this is the diagnosis and going ahead with the treatment is a problem. And the biggest gap is where the tuberculosis is, because most of the patients are treated for lung, in any case lung scenario, are given ATT for any persistent symptoms, and we have seen in our case scenario that many of these patients turn out to be malignancy later on, where their ATTs do not work.
Okay, Dr. Jain Kumar has got some question.
Sure.
First of all, I compliment Dr. Mohit Agarwal for a wonderful presentation. You presented in a very simplified way so that everybody can understand. Now, my question is, see, in our department, railways, a large number of women employees are working. There is a structured periodical medical examination for all our employees. But for women, there is no special periodical medical examination, especially keeping in view this breast cancer or cervical cancer. So now my question is, do you recommend that the departments like central government department like railways, there are a large number of workforces employed in the field, we can have some screening camp for the early detection of breast cancer or even cervical cancer in the workplace itself. I mean, if the patient, we ask the patient to come to the hospital, many of the patients are reluctant. But workplace screening camps are more successful. So what are your remarks on that?
So the beauty of screening protocols, especially in a breast and cervical cancer, are that they do not require any big setup. Any mobile van with a mammography, or maybe you must be having at your railways hospital, and obviously a cervical screening just requires a pap smear, which is so simple test that we all doctors understand. I firmly believe that we should be organizing these camps periodically so that the awareness goes forward to these individuals and the employees which are working. And also, if possible, I would like to get them added onto your annual screening protocols annual medical examinations. After an age of 40, if every lady has to undergo a mammogram, your half of the job is done. And after the age of 25, if just a pap smear is done, how simple would it be for any individual?
Oh, quite right. Thank you.
Yes.
Dr. Mohit, there is one more question regarding this. Since you are a medical oncologist also, that will be a great help for us. Like regarding this targeted therapies. Now immunotherapies are available, targeted therapies are available, but we have seen they are very costly. And number two, as medical heads, we have to take decisions whether that is admissible or that is not admissible. Like for many organizations now, it is for those who are having under insurance based insurance people, they give clearance, but for organizations where medical is totally reimbursed or taken care of by the organization, then the medical team or the medical standing committee, they have to take a decision whether it is admissible or not. So what we have seen that many targeted therapies or immunotherapies, they have been approved by FDA, or they are approved in some other countries, but Drug Controller and General of India, they have not given any clearance for them. And doctors in India, they are using it on trial therapy. So is this treatment admissible as per your advice?
Sir, this topic was also raised in our hospital, and this was recently raised in ECHS as well. So what I understand is that as per in India, our practice should be based on the DGCI approvals. So any drug which has been approved by DGCI, then we should not be, holding our hands back and should be giving that drug. However, for the drugs which are FDA approved and not DGCI approved, but we think that the patient might benefit from them, then that cases should be taken on a case-to-case basis. And we, whosoever is prescribing that drug, might make a format and present it to the authorities which are going to actually approve it, and take that case-to-case basis for an approval. It should not be a blanket approval, what I believe.
Yeah. So that is what we are doing, and we are taking help from you all medical oncologists and the people in the field of oncology. So Dr. Sudha Ramachandran, she is our senior member, past president she is from Tamil Nadu, Chennai. She might be having some question or some comments, ma'am.
Hello, ma'am.
Yes, good evening, Sandeep. Thank you, Dr. Agarwal. You laid out all the problems that are faced by any doctor, whether oncologist or not, when we have to deal with the big C. I have a couple of questions. One is there any advance in reconstructive surgery for any of these surgeries that are done for malignancy, like face, tongue, etc., whether we have progressed to that level? And the second point is, how much are people willing to come for follow-up and continue with the treatment? Thank you.
Yeah. So, ma'am, in terms of reconstructive surgery, there have been a lot of developments. And if we talk about especially breast, the reconstructive surgeries have gone to such a good extent that it is really now, the morphology of an individual is absolutely maintained. And you have nipple sparing surgeries where the architecture is also absolutely maintained. Now, head and neck area is a challenge, but there also now you have some areas of free flaps which you are being used, where the morphology is try to be retained as much as possible. So if we talk in terms of the development, obviously we are much ahead what we were, say, about 2, 3, 5 or 10 years back. But obviously there are much more scopes of improvement, especially in the head and neck areas, and obviously in other areas as well. But the reconstructive surgery is progressing at a very rapid pace. Now, coming to your second part, again, as difficult it is to get the patient to the OPD for the first time for the purpose of diagnosis, the more it is difficult to convince the patient for treatment. And after the treatment has been done, if the patient has achieved a cure, then it is thoroughly more difficult to get the patient to come for a follow-ups. So there I understand that we need to actually go for education and awareness also. Now what happens, what I feel the problem is that as a doctor, as an oncologist, when I tell my patient, no, you have to come every 6 monthly to show me, they feel that no, doctors are always like that, you come and show and come to the OPD. The awareness is not there. Where I find in India is that when all of us would spread this message that, picking the right thing at the right time would make a difference, then patient would understand that why are we asking for follow-up. When now we tell them and we treat a patient of breast cancer, tell them now you come after 3 months with report, they'll come once or twice. Then once we start asking them especially to come annually, they will say, oh sir, hum bhul gaye the, de tha, wo tha. They have a lot of troubles. Everyone is busy in life. But the awareness and message needs to be spread, then only the compliance will be maintained.
Yes, awareness is very important, and awareness is required for diagnosis also, and for treatment modalities also. Patient should be rightly advised for the right treatment, because I think in most of the hospitals they've got a medical board, tumor board for deciding the modality of the treatment before they go for any particular modality. And now this. Plastic surgeons, they are the part of the surgical oncology team, and in your hospital also Dr. Sandeep Mehta is there. He is in Dr. Kapil Kumar's team, and from Dharamshila to Rajiv Gandhi to BLK and now to Fortis, this whole team is moving, and Dr. Pankaj Pandey also is also there. So now reconstruction is a part of important part of surgical oncology, because whenever you diagnose a tumor, you have to go for a ruthless surgery, and ruthless surgery definitely will cause a lot of disfigurement, and that has to be taken care of by the plastic surgeon. So it is a teamwork, and oncology management is not a single person's job. It has to be a teamwork, and medical oncologists, they also play a great role. And as you rightly said, that we should not be afraid of chemotherapy, because chemotherapy is not painful. It is given by the right hands at the right time, and problem occurs when it is being given by paramedics who are not so much aware of the side effects, and there is a lot of extravasation of the drugs, and a lot of people, they are coming with swollen hands or darkened hands, burning of the tissue, and the side effects are also, yes, they are important, and we have to convince the patient, yes, all these things will happen definitely, like constipation or nausea, or these problems will definitely occur, and alopecia especially. So we have to make the person more comfortable for oncology management. And with this, I think if there is any other question, panelists can raise hands. Else we can conclude this session, because Dr. Mohit has given a broad overview, and he has clarified 2 and 3 of my queries which we face day in, day out. And Dr. Mohit will keep in touch, and Dr. Kapil and his group is our good friend, our seniors. We have learned a lot from them, and they have been associated with us for last 27 years. So with this, I think I thank you very much for sparing your valuable time for this session. And
so the honor is all mine. I'm happy to connect over here, and I'll be always there if my services are required in this association anytime.
Yeah. There is one more last question from Kailasam. He is asking for any word about the occupational cancers.
So occupational cancers are a very broad subject, and very specific also, because you have occupational hazards with respect to where you are working, where the most problems, common ones, are being faced in terms of the lung cancers, where you have asbestos exposure, or industries where are using a lot of silica and all stuff. Then you have problems of bladder cancer, where those dyes, aniline dyes and extra are being used. So their occupational exposure can only be minimized by taking, I'm sure that whenever one is working in some sort of industry, one understands the risk and hazards to it. Like being a doctor, we are much more exposed to COVID, so that is an occupational hazard to us. So we need to understand how do we save ourselves, and then we save our patients. Same way, any person working in an industry should know that what occupational exposure they are suffering from and what are the ways to minimize it. And if they require any help from an expert, they can contact any of the experts and let them know that what can be the ways out where their occupational exposure to any of these substances is reduced.
So Dr. Mohit, it gives a clue also to all the treating oncologists also, that whenever some patient comes, they should always ask what is your occupation, because that is very important to correlate what is the exact cause for this cancer. And now with the new jobs with this IT sector, night shift, night duties, a lot of other cancers, ovarian cancers, breast cancers, they are all hormone related, and because of the hormonal changes due to the diurnal effects, these are also on a rise. So although we have taken a very general topic this time, but we will come out with some specific topic with you next time. And with this, I thank you very much for sparing your valuable time, Dr. Mohit.
Thank you.
Thank you.
Thanks.
Thank you. So our next speaker is our own Dr. Rajiv Jain, Vice President AUSD, and he will give us a broad overview of the epidemiological status across India, locally, and across the globe. And as you all know that, yes, the pandemic is still prevailing, and it is endemic in many countries and continents, and even the countries which were not exposed earlier and where we saw a good control. But again, now the pandemic is raising its head, and what we have seen is the countries which are less vaccinated, or the vaccine availability is not proper. There the cases are on rise, and especially where the cases are on rise in the vaccinated countries also, the deaths are less. So that has been observed by the scientific community. And today, let us congratulate that we have additional 5th vaccine in our armatorium, that is the Johnson & Johnson single dose vaccine. And Dr. Rajiv Kumar Jain, may I request you to start your presentation.
Good evening, friends. Once again, this is Saturday evening, and we again review the current epidemiological situation of COVID-19, as we have been doing for so many weeks, and we are watching how dynamic is the epidemiology of COVID-19 pandemic. It changes every day, it changes every week, and it changes every month, and it's changing forever, day and night. So it's historical pandemic, much more lethal than even influenza pandemic more than 100 years back. Let's see the situation as on date. Let's see the COVID-19 cases reported weekly by the WHO region and global deaths as of 3rd August 2021. That is the last official weekly epidemiological figures released by the World Health Organization officially to all the countries of the world. This is the situation. This is a graph from 6 January 2020 to 26 July 2021, and up to 3rd of August 2021. The data is collated in terms of WHO regions. And what do you see? You see, in terms of cases, there are 3 humps, 3 peaks, and the 3rd peak is an ongoing peak. The 3rd wave is on globally. That is the first observation. Second observation that we make is the contribution by the regions is dominated by number 1, Americas in yellow, number 2, Southeast Asia in violet, and Europe in green, light green actually. And Eastern Mediterranean region is now increasingly contributing cases, which is in little bit darker green. But also we must observe Western Pacific region is showing a very high gradient in the recent past, specifically last 3 weeks. And if we look at the graph, the line, that is the black line where is of deaths, global deaths, we find first, second, and third peaks in the past, and the fourth peak is on, though recently the deaths peak is going down. That is the observation as per this graph, overall graph of global pandemic. Then let's go and find through the numbers. Next slide. This is the region-wise trend of cases, which shows that out of 100% cases, which are 40,33,000 in the past week, the largest contribution was by America, 30%, Europe 25%, and Southeast Asia 21%. 11% by Eastern Mediterranean, and Western Pacific 8%, and Africa 5%. But if you see the week-on-week change overall, even though there was increase of 3% in 1 week, but what you see distinctly that the two regions showing very high growth week on week were Eastern Mediterranean region, 37% increase, and Western Pacific 33% increase week on week. And Southeast Asia showed 9% increase week on week. But Europe and America showed -3% and -9%. Europe -9% and America's -3%. That is the current situation in terms of cases for the weekly cases. Now we look at the deaths. Out of 100 deaths, 32 and 34% deaths were reported by Americas and Southeast Asia region, respectively. 12% deaths by Europe, and 8% by Africa, 9% by Eastern Mediterranean, and 5% by Western Pacific region. But if you see the week-on-week trend, the highest increase in deaths, that is 31%, and was reported by Eastern Mediterranean. And over this, the Western Pacific region showed an increase in terms of death by 48%. So what we observe, the deaths are going very steeply in Eastern Mediterranean region and Western Pacific region. So 29% decrease in the deaths occurred in the Americas region, which is North America and South America, and 2% decrease in deaths in Europe, and 2% decrease in deaths in Africa. So what we observe overall, it is moving from one continent to another, one region to another region, and it is continuing its march throughout as it has been doing in the past 1.5 years. So it's an ongoing pandemic. It's a pandemic in evolution, so to say. Let's go further and see what is happening. Next slide, please. This is the WHO coronavirus disease dashboard as on date today, half an hour back. The global cases, if you see, out of 41,98,000 cases reported in last 7 days, 13,05,000 cases by Americas, 10,66,000 by Europe, and 4,69,000 by Eastern Mediterranean region, and 8,13,000 by Southeast Asia region. And Africa is now showing 1,86,000 cases on a weekly basis. And Western Pacific is also showing 3,56,959. So we can see it is evolving and it's more widespread across WHO regions. Earlier, you must have seen Africa and Western Pacific were having very less number of cases. Now they're increasingly showing high number of cases. Let's go further. Let's go to and see the next slide. This is the slide which shows you the condition of the states in terms of countries which are showing the maximum number of cases in the last 7 days. And what do we find? Once again, United States reported at the top number, that is 6,49,000 out of 41,98,000 cases globally. India is number 2 position, 2,84,000. Number 3 is Indonesia, such a small country, is number 3, 2,35,000 cases. Iran, 2,31,000 cases. Brazil, 2,29,000 cases. United Kingdom, 1,81,000. Turkey 1,64,000, Russian Federation 1,60,000, France 1,44,000, Thailand 1,36,000, and Malaysia 1,25,060 cases. So it is still spread across countries, across continents. Next slide, please. This is a ranking of the countries in terms of deaths newly reported in the last 7 days. Out of 64,843 deaths reported globally, as much as 11,699 were reported by a very small country, Indonesia. And the second highest were reported by Brazil, 6,400. Third highest by Russian Federation, 5,530. And the fourth highest was continuing to be India, 3,537. United States reported 3,044 deaths, Mexico 2,931, Iran 2,554, South Africa 2,442, Myanmar 2,320, Argentina 1,925, and Colombia 1,894. So what do we see? Again, we see it is spreading from one country to another and one continent to another continent. So it is evolving pandemic as on date. Next slide, please. Now we come to Southeast Asia region, and let's see. The region reported 9% increase in new cases as compared to the previous week, over 8,41,000 cases. While the number of weekly deaths remained similar to the previous week, that is 22,000 deaths. The highest number of new cases were reported from India, that is 2,83,923 new cases, that is 7% increase. Indonesia 2,73,000 cases, that is 5% decrease, and Thailand 1,18,000 cases, 26% increase. Remember, Thailand showed 26% increase. Cases from these three countries accounted for 80% of new cases being reported from this region. The highest number of new deaths were reported from Indonesia, that is 12,444, and it showed 28% increase in deaths. India showed 45% decrease in deaths, that is 3,800 new deaths. Myanmar showed 24% increase with 2,620 new deaths. So it's lurking in our neighborhood, that is Thailand, Myanmar, and Indonesia. We must remember it is moving in Southeast Asian countries, and it is very much there. And the same is shown by the graph. Next slide, please. Let's come to India now. This is today's position to 38,705 new cases, 616 deaths, and 17.8 lakh tests yesterday. 7-day average test positivity 2.4%, 4.06 lakh active cases, growing by 0.13%, total 3.19 crore cases, 4,27,401 deaths, and 550.03 crore vaccination. Very important landmark. 50 crore vaccination doses given. 43.3 lakh doses were given yesterday. Let's go to the next slide. This is the very important slide, that India is like a continent. Very huge diversity, where in confirmed cases, we find Kerala, Maharashtra, Andhra Pradesh, Tamil Nadu, Karnataka. The entire South India is having a number of cases reported. Out of 38,000 cases reported, Kerala reported 19,948, 50% cases. Maharashtra is still reporting more than 5,000. Andhra Pradesh 2,200, Tamil Nadu 1,985, Karnataka 1,205. I'm finding some noise in the, yeah, that's good. Thank you for muting. For deaths, still Maharashtra reporting highest number of deaths, and Kerala is reporting the same number of deaths, 187 each out of 616 deaths. So more than 50% deaths were reported from Maharashtra and Kerala. Odisha reported third highest, that is 66. Karnataka reported 36 deaths, and Tamil Nadu reported 30 deaths. So deaths continue to be reported from a diverse regions of the country. Tests per million per day is, Indian average is 1,300 per million per day. But what we find, Rajasthan reported only 369 tests per million. West Bengal 450, Punjab 736, Nagaland 854, Madhya Pradesh 895. Very low number of tests per million per day from these states. If we see 7-day average test positivity rate, Indian average is 2.4, but the top highest I reported from Mizoram 13.2%, Manipur 12.6%, Sikkim 12.3%, Kerala 12.2%, Meghalaya 10.0%, and Nagaland 6.4%, Arunachal 5.2%. The Northeast and Kerala is continuing to show high test positivity rate. If you see 7-day average daily growth in terms of percentage, even though Indian average is 0.13%, but Mizoram is showing 2.04%, Meghalaya 0.82%, Manipur 0.74%, Sikkim 0.71%, Kerala 0.6%. So we find entire Northeast still is showing very high 7-day average daily growth, including Kerala as well. If you look at vaccinated person with at least one dose in terms of percentage, even though Indian average is 26.48, but Bihar is showing 18.03, Uttar Pradesh is showing 16.91, West Bengal is showing 22.84. So these states are still lagging in terms of vaccinated persons with at least one dose in terms of percentage. Let's go and see what is happening in the state. But before this, I would like to show you a video where Dr. V.K. Paul, a member health of the Planning Commission, that is the Niti Aayog, is deliberating on the current situation and his overall analysis of the current situation. Let's listen to him for a while.
आज आपके सामने जो रिपोर्ट प्रस्तुत हुई है, डेटा प्रस्तुत हुआ है, मिक्स्ड पिक्चर फिर सामने आई है। हम देखते हैं कि जिन ज़िलों में 100 से ज़्यादा केसेस हो रहे थे वो कम हो गए हैं। हम ये भी देख रहे हैं कि केस हाई पॉजिटिविटी वाले भी ज़िलों में चेंज आया है। बिफोर दैट ओवरऑल पॉजिटिविटी रेट में डिक्लाइनिंग ट्रेंड है और जो हाई पॉजिटिविटी के ज़िले हैं उनमें भी गिरावट आई है, लेकिन वहीं पे एक सिग्नल मिलता है कि नए ज़िले भी हाई पॉजिटिविटी रेट के साथ जुड़ रहे हैं। एक सिग्नल ये मिलता है। दूसरा, आपके सामने जो डेटा और मैप दिखाया गया उसमें ये भी दिखाया गया कि हमारे कई प्रांतों में, कई राज्यों में रिप्रोडक्शन नंबर जो है वो 1 से ऊपर पहुंचा हुआ है और बढ़ रहा है। और continuing high active case load and pandemic load in the state of Kerala continues to be a very significant worry. तो mixed picture है और आज के concerns में हिमाचल, जम्मू कश्मीर, लक्षद्वीप, तमिलनाडु, मिजोरम, कर्नाटक, पुडुचेरी और केरल, ये राज्य जो हैं वो चिन्हित हुए हैं आपके सामने। So mixed picture, and it only emphasizes the need for us to use the full armamentarium of pandemic control and pandemic response, जिसको कि लव अग्रवाल जी ने एंड में बड़े अच्छे तरीके से समझाया आप सबको और उसको दोबारा एम्फेसाइज किया। द फैक्ट रिमेन्स कि अगर हम ये मानते हैं कि कंपैरेटिवली स्टेबल है सिचुएशन, ओवरऑल नंबर्स स्टेबल हैं, किसी हद तक कम भी हुए हैं, कल का डेटा अगर देखें तो फिर एक विनती है कि कॉन्टैक्ट ट्रेसिंग करें और कॉन्टैक्ट्स को क्वारंटाइन करें। फिर ये विनती है कि आप जहाँ पे क्लस्टर ऑफ केसेस है वहाँ पे कंटेनमेंट जोन्स बनाएं ताकि वायरस वहीं तक सीमित रहे, उससे बाहर नहीं जाए। इसके ऊपर जितनी भी हम मेहनत कर सकते हैं इस अंश पे, इस पार्ट पे, वो कभी मैं कहूँगा कम नहीं होगी, क्योंकि अगर हम उसी जगह पे वायरस को कंटेन करते हैं, चेन्स ऑफ ट्रांसमिशन को लोकलाइज करते हैं, सप्रेस करते हैं, वो नहीं फैलेगा। तो आज पर्टिकुलर रिक्वेस्ट है सबसे, आम व्यक्ति से भी, एडमिनिस्ट्रेशन से भी और राज्यों से भी, टेक्निकल टीम्स के साथ भी, डिस्ट्रिक्ट टीम्स के साथ भी, कि इस तरफ अपनी जो नज़र है, अपनी जो मेहनत है उसको बिल्कुल कम नहीं करें। और इसके साथ साथ कोविड अप्रोप्रिएट बिहेवियर, भीड़ में नहीं जाना, अननेसेसरी ट्रैवल को अवॉइड करना, ये भी एक इम्पेरेटिव है जो हमारे सामने अभी दिखाई दे रहा है। हमें जानना है, हमें मालूम है और हमें ये भी जानना है कि डेल्टा वेरिएंट हमारे देश में फैला हुआ है, डोमिनेंट प्रॉब्लम है, वेरी डोमिनेंट प्रॉब्लम है, और यही डेल्टा वेरिएंट ग्लोबल पेंडेमिक का भी अब हिस्सा बन चुका है। और अमेरिकाज़ में 30% इंक्रीज़ हुई है न्यू केसेस में, वेस्टर्न पैसिफिक रीजन में WHO के 25% इंक्रीज़ हुई है। तो द पेंडेमिक इज स्टिल रेजिंग and pandemic is still persisting. The second wave is persisting in our own country And we are concerned that some states have an R naught which is in the wrong direction. Please remember that this R naught had come to 0.6 and below, or so, around that. And now if it is above 1 and if it is rising in some states, it is truly a cause for concern, shows that the virus wishes to expand. Pandemic has a tendency to still expand, and we must curb it with all our might. Mera second.
Then let's go back to the slide now. After listening to Professor V.K. Paul, this slide shows what he was talking about, that is the R naught. R naught on date. Look at this figure. What do we find? R naught a month ago in Kerala was 1, now it is 1.06. Tamil Nadu it was 0.8, now it is 1.05. Karnataka it was 0.8, now it is 1.04. Andhra it was 0.9, it is now 1.03. Maharashtra it was 1, it is 1.01. Assam was 0.9, it is 0.85 now. Odisha it was 0.9, it is 0.83. So we find most of the states it is rising. States with 100 to 1000 cases as on August 5, we find Himachal, it has risen from 0.89 to 1.3, Jammu Kashmir 0.88 to 1, Chhattisgarh from 90 to 1, West Bengal it has risen from 0.76 to 1, and Telangana from 86 to 0.96. So it is rising in the states, the trend is not good. If you look at states with less than 100 cases on August 5, again we see a rising trend. R naught a month ago in one column and R naught now. Madhya Pradesh from 0.87 to 1.31, Rajasthan 0.65 to 1.03, Delhi 0.65 to 1.01, Uttar Pradesh 0.73 to 0.9, Haryana 0.68 to 0.88, overall India 0.93 to 1.01. So it is increasing transmission. That is the indication. Next slide, please. This is the map of India, which shows a cumulative change in confirmed COVID-19 cases across Indian districts in the past fortnight. And what do we find? India confirmed cases changes 5.64 lakh. And what we find? Malappuram, Thrissur, Kozhikode, Ernakulam, Palakkad, Kollam, Kannur are dark brown. Tirunanthapuram, dark brown. Alappuzha. But we find Pune in Maharashtra also. Kottayam, Ahmednagar, Maharashtra, Sangli, Maharashtra, Satara, Maharashtra, Kasargod, Kerala, Aizawl, Mizoram, Kolhapur, Maharashtra, Wayanad, Kerala, and Solapur in Maharashtra. So what we find dark brown is in Maharashtra and Kerala. So still on. And we find Mizoram as well. So that shows 7,000 plus confirmed cases for the past 14 days. And on the other hand, we find green, which are 0 confirmed cases for the past 14 days. So mixed picture. Next slide, please. This shows India was able to detect only 1 in 33 cases on May 31st, as estimated from the 4th survey. And now we are missing, detection rate has to increase. Next slide, please. This is the current countries, territories, and areas reporting variants of alpha, beta, gamma, and delta as on 3rd of August, at the WHO official release, the latest one. And it shows alpha is in 182 countries, beta in 182 countries, gamma in 81 countries, and delta in 132 countries. So it, in fact, gamma is in 135 countries at the moment. So, and India is having all 4 variants of the of alpha, beta, gamma, and delta of COVID-19. Next slide, please. Now we discussed today India's gender gap in vaccine coverage has narrowed. India had delivered 330 million vaccines by the end of June, but only 86 doses were administered to women for every 100 doses for men. This was 6 points below the country's female-male ratio of 92 to 100 and raised concerns about gender inequality and its public health consequences. However, July saw some improvement. Of the 463 million doses that were delivered, 88 doses went to women for every 100 for men. Thus, this slight improvement was primarily driven by Tamil Nadu, West Bengal, and Madhya Pradesh, 3 large states that closed the vaccination gender gap the most last month. Tamil Nadu's ratio went up from 87% by the end of June to 95 by July end. West Bengal improved it from 79 to 85, while Madhya Pradesh now improved it from 79 to 83. However, the progress on this front was held back by 8 states where the gender gap widened. 2 are large states with over 5 million population, that is Gujarat and Haryana, where the female-male ratio of doses stands at 83 and 81 respectively. The inequality in vaccine deliveries is more pronounced at the district level, especially in some hotspots. Among the bottom 15 districts, 8 belong to 4 northeastern states. Kifir in Nagaland and Noni in Manipur have the lowest coverage of women, with less than 60 women vaccinated for every 100 men. But in both the districts, coverage has improved in the last month. By the end of June, this two had only vaccinated 44 women per 100 men. This is an area of concern. So we need to do micromanagement of vaccination in terms of gender equity. Why? And we should increase the female male ratio. Next slide, please. This is the same figure which is shown in figure graphically, which I have just discussed. Jharkhand, UP and Bihar have delivered less than 300 doses per 1,000 people. And Tamil Nadu led the country in narrowing the vaccination gender gap in July. You can see end of June is in gray and red one is end of July. You can see how gender gap has improved. While on the other hand, wider the states at the bottom group, they have widened the gap. Haryana, Meghalaya, Gujarat, Arunachal, Sikkim, Goa, Ladakh have widened the gap. So there's a mixed picture. Next slide, please. This graph shows Bangladesh improves vaccination rates with fresh supply of doses. If you look at the figure, Bangladesh weekly change in COVID-19 vaccine doses per 100 people in percentage. Bangladesh is 29.1, Philippines is 25, India is only 7.7. So in rate of increase is very less. Mexico 7.5, Indonesia 7.3. Globally, Bangladesh led the weekly increase in vaccination coverage among the top 10 most populated countries, registering a 29% growth, up from 3.6% last week. Its coverage, however, is still low at 8.6 doses per 100 people. The COVAX initiative, that is causing a little concern because it distributes vaccine to lower and middle income countries. Bangladesh ramped up after receiving 6 million Pfizer-BioNTech vaccines through COVAX, another 0.25 million AstraZeneca vaccine from Japan late last month. India saw a 7.7% increase weekly coverage, taking the 3rd position after Bangladesh and the Philippines. The US was at the last position, but it has already given 104 doses per 100 people. China continues to ramp up as it went past the US in terms of coverage. It has so far given 117 doses per 100 people. Next slide, please. This map of India shows 9 of top 10 districts with most cases are from Kerala. These are the 3 hotspots. After a slight decline in last week of July, new reported cases went up in the country by 5%. This week to 284,000. Kerala contributed almost half of this, reporting 122,000. 9 of India's top 10 districts by cases last week were from Kerala. Malappuram saw a sharp jump of 27% to 24,485 new cases and led all the districts in India in new cases this week. Besides Kerala, both Mizoram and Meghalaya also saw a rise in active cases in each of the last 2 weeks. These 3 states currently have 47% of the total active cases in India. 2 districts in the northeast, that is East Khasi Hills in Meghalaya and Agarwal in Mizoram, saw the sharpest rise in active cases in the last 7 days. Last week, East Khasi Hills had 2,065 active cases, which rose to 2,135 active cases this week. Likewise, in Agarwal, it rose by 20% to 9,375. Next slide, please. This graph shows as Olympic Games progress, Japan's vaccination pace is dropping. China is leading. Globally, India maintained its 4th spot in vaccine coverage among the 10 most populous countries. So next, let's go to the next slide. This shows the decline in deaths. Kerala and Maharashtra saw a decline in reported deaths last week. India reported 3,626 deaths this week, down from 6,254 deaths in the first week of July, which though included Maharashtra adding 318 deaths from a prior period. So what we find, deaths are still occurring across Maharashtra and Kerala are leading in terms of deaths. So resurgence of cases in some parts of India and a growing transmission rate should make all of us cautious and prompt the center to speed up the vaccination drive. That is the conclusion that we can draw from the entire discussion today. But before closing, I would like to show you two videos which have been just released minutes before we started this webinar, which is important for all of us to keep ourselves moving. Let's go and see two momentous videos now. Let's see the event which led to this national anthem being played in Olympics in Tokyo 2021. Let's see the event now.
That. And we talked about form coming in. He is in career best sparkling form.
Look how wide his block is there. Incredible.
So effort, dedication, focused, concentration, and effort which is sustained over time does bring results. So we should continue our efforts for containment of COVID-19 in our regions, in our country, in our neighborhood, everywhere, day and night. And we should continue to adopt COVID appropriate behavior and improve vaccination in our country. Thank you so much for patient listening for today.
Thank you, Dr. Rajiv, sir. It was really a glorious moment for we all Indians to have won this gold medal. And yes, this was despite so much gloomy situation across the globe. And when the Olympics, they are just being played without the spectators in the stadium. And still India could manage this. We won this gold medal for the first time in the Indian history. So yes, persistence and continuous focus on your target, that is the most important thing. And as we all know that this pandemic is persisting across the globe, and this particular Delta variant is prevalent across the globe, and it is still not under control. So what is important is testing, contact tracing, containment zones wherever the number surges, and in this way we have to suppress the chain of transmission locally. We need to avoid the crowds, follow the COVID appropriate behaviors, and over and above that, vaccinate ourselves. And as rightly said, some more than 50 crore population has got now some sort of vaccination. They have been vaccinated, and now we can gradually move towards a period of normalization if we are following all these norms. And with this, sir, I would request the panelists, if they have any questions for you, sir, then they can just unmute themselves and they can ask the question.
Good
Yeah,
evening,
Dr.
sir.
Yeah, Dr. Sanjay Rautiwala.
Good evening, Dr. Sanjay.
Yeah, your presentation is always fantastic, as always.
Thank you.
Yeah. Secondly, basically, yesterday, Health Minister said that they have ramped up the production commitment from both the companies. So they will go for 11.4 crore doses, and I think more than 4 crore for Covaxin. But what is your guess by December end, will we be able to cross 150 crore doses?
It's a
Current
difficult
speed?
target, but if we see the huge ramp up that is being promised from September, I would say it would increase, but October definitely the increase will be very high in terms of vaccine availability. both the vaccines, and in addition, we will have new vaccine. Of course, you've seen today the J&J vaccine, single dose vaccine, and Covax also coming. That Serum Institute of India also started marketing from October onwards. So there is a positive feeling that we shall get more vaccine, not only manufactured, but also delivered at the sites where vaccine is required. So that's a positive thing. We should be working with a positive attitude, and I feel the target is achievable if we continue our focused attention to manufacturing, logistics, supply, and vaccine hesitancy removal with good communication strategy. It should be possible. Surely, it should be possible.
And secondly, actually, if we will think the particular vaccination as a whole, do you think by November end, booster doses will be required to be taken
That's the
for those
thinking
who
which is
have?
going on at the moment, especially for healthcare workers, because they were the first to receive the vaccine. The issue is under examination by the National Technical Advisory Group, and we should be hopeful some decision will crop up. But we have to remember, one has to balance the two, vaccinating the unvaccinated as well as giving a booster shot. As you know, number of new countries have come up which have started giving booster doses. Now you must have seen 2 countries in Europe, and Israel had already started. So increasingly countries in Europe have started. We think that there should be a positive decision, and there should be vaccine available to be given the booster dose as per the plan or as per the need which is felt in view of the Delta variant being the predominant strain in this part of the world now.
Right. Thank you, sir.
Dr. Rajiv sir, any insight about the WHO approval for the Covaxin? Because many of Indian citizens, they want to go abroad, especially to US, and especially the children who are going for studies to US. This Covaxin is still not approved, and it is not incorporated in their passports as Covishield is. So any insight, news about it?
Well, this is a difficult issue because WHO, it is not in their domain to allow or to ratify one vaccine or the other. In fact, WHO official policy is against vaccine passport. That's part one. Each country has to decide on its internal matters, and it has to decide its own policy. And you must have seen how countries are softening their approach to allow people with vaccinations. And at the moment, because Bharat Biotech has official agreement with a company in US for manufacturing this vaccine in US, and that country's Jain has already applied to FDA for approval, and that is going on. Communications are going on. Clarification that was asked by US FDA are being provided. Let's hope something positive should result in positive outcome. European agency also is being pursued by Serum Institute of India as well as AstraZeneca, and hopefully some decision should be coming forward in the forthcoming week or fortnight. That's what the positive aspect of this issue is at the moment. But US, you must have seen, is now changed India from a red to amber. So that is also a positive aspect. So this color will change as we show effective control on the ground and improved vaccination. 50 crore is a landmark, but the total vaccine single dose in India is 26% of the population. As you know, India had already softened its approach towards providing the vaccine to international travelers. So that approach also is helping.
Sir, any insight about the single dose Johnson Johnson vaccine? There's one question from Dr. Kailasan.
Yes, very, very apt question. It is important to understand that Jain vaccine. Somebody needs to mute. Dr. Tyagaraju's mic is on. Yes. this, as you know, both Serum Institute vaccine and this current vaccine is from the same platform as J&J vaccine. That is a vector vaccine. In fact, Sinovac also is building similar vaccine with the difference. J&J is a vector vaccine. So what we hope is now, only thing is it doesn't require 2 doses. That's one advantage is it does not require kind of coming back to the system again. So it's a 1-dose vaccine. That's another advantage. And availability would be an issue because there is no manufacturing plant for J&J vaccine in India at the moment. So it provided vaccine availability on the ground because of the prior commitment by the manufacturing company to supply to other countries. Let's hope J&J single-dose vaccine may be available sooner than the other vaccine. That's what the hope is. But it's good to give approval in terms of EUA because we should not be, this availability will not be delayed because of regulatory approvals. That's a positive aspect.
Right. Dr. Tyagara sir, you have raised your hand. You have to unmute. You have to unmute. You have to unmute. Dr. Tyagara sir.
Sir, good evening. Good evening. We are all assembled in DC meeting. I am just not missing your this one. And hello, excuse me. Our Honorable Secretary of IAOH is there, Dr. Sandeep Sharma ji. And Dr. Srinivas, Dr. ex-president is there. Dr. Palaksha ji, our senior, and Dr. Raghuram ji, our senior is there, sir. I am introducing all of them. Dr. Naveen, our president. We are having a EC meeting, sir, and we are. And I am not missing. I am really started with Dr. Rajiv Jain's lecture. I have started, and Dr. Suhas is there. Hello. Sir, Dr. Suhas wanted to wish you.
How are you?
Yeah, we are all fine, sir.
So nice to see you. Great. And Dr. Naveen, congratulations once again.
Sandeep, good evening. Good evening.
You have migrated from our branch to Karnataka branch.
Very nicely you are conducting the meetings.
Yeah, thank you.
Sandeep.
Thank you, sir. Thank you very much. And it was nice to connect with the whole EC of the Karnataka branch. And special thanks to Dr. Tyagara for organizing this. And all senior members from Karnataka branch. Sir, continue with your efforts along with our efforts, sir. We will definitely take an IUS.
Dr. Srinivasan is that yours is one of the best.
It was very good. Today is the first council meeting of our AOHA. Our new president has taken over. Dr.
Okay,
Naveen.
Yeah,
This is the first EC meeting that we had for the Karnataka branch today. Okay. So we were all planning for our conference, which we could not do so far, as well as the AGM and other things. Just it is over. We'll finish our food and go back home because of the prevailing COVID situation. You know, we can't stay back for a long time in hotels. That is the thing. Okay. Anyway, very nice.
Congratulations to all new teams, sir.
Okay. All the best. Wish you all the best.
Your physical meeting today is telling us that we should also go for a physical meeting.
I will talk to you sometime over telephone. I will talk to you. Okay.
Sure.
Thank you.
Thank you very much. Thank you. Dr. Tyagara,
Thank you.
Thank you very much.
Thank you, sir. Thank you very much.
Thank you. So it was nice seeing IUH branches now starting their physical meetings and yes. Dr. Tyagara, sir, you have to unmute. You have to mute yourself.
Mute yourself.
Yeah. So it was nice to see people now started meeting physically, and but still we have to take all precautions because still the pandemic is not over and it is persisting. And as rightly said by Dr. Rajiv Jain sir, that that we have to take all necessary precautions, get ourselves vaccinated, and even ask our neighbors, our people who are we in touch with socially, or who are our housemates, or drivers, or because our local community whom we come day in and day out in contact, we should persuade them for their vaccination also, because we will be safe only when they are all vaccinated and they are free from the virus. So I think with this we can conclude this session. It was a great day for India, for AUSD, and for IUH also. So with this, sir, we'll conclude this today's session, and let us enjoy the gold medal of Olympics, and stay healthy, stay safe, so that we can take care of
Thank you so much.
and
Thank
take
you.
care of others also. Thank you very much, sir. We'll see you all next week with a new guest speaker and new topic. Thank you, sir.